So we'll just give you a brief high-level summary. Thank you for being so engaged in the conversation. Some of the main themes that have come out of your discussions today when you're thinking about moving forward and redesigning the systems across BC. The first is around reimagining relationships, and that's reimagining the relationships between us as health authorities, reimagining the relationships between health authorities and their own home community-based organizations, and reimagining the relationship between patients and providers. All of those need to be kind of addressed and looked at and reimagined because in order to redesign this system, we need to look at how the older paradigms are maybe not as effective and have got us to the point where we still have lost that 10 to 20% of people with HIV. They're still falling down a crack for us. We need to explore what organizational barriers exist and also what professional and procedural barriers. There's a really good thing in healthcare that we have around keeping the status quo. And anyone who's been a healthcare leader or worked in healthcare has heard before, well, we just don't do it that way. We don't do that here. No, we can't do that. Our default sound in healthcare is no. And largely that's because it might cost money, and there isn't any. So this time, there is some money. And we can also get some savings by maybe redesigning things. So having a real clear look at our procedural and organizational barriers. Building HIV into existing healthcare systems, so not having to set up whole new individual systems of care, but including it into some of the existing screening that's done, for example. So ensuring that it's offered during PAP tests, you can look at introducing it into acute care, for example, or ensuring that your abortion clinics locally are doing an HIV test routinely for people, because I can assure you that it wasn't occurring in Vancouver and it isn't occurring elsewhere. So looking at the kind of the quick wins, where should HIV testing really be offered? And then how can we offer it into all of our existing departments? People talked about making it easier for providers to make good decisions. That we often ask doctors and nurses and frontline healthcare workers to do more with less, but we don't put the tools in place to enable them to do it easily. An example I've got of that is around IT systems and the use of information technology. I don't know what it's like in the rest of the province, but in Vancouver, I think we're on Windows 1953. So how information systems can be bolstered, what investment do we need to make in information systems to make our lives easier and get this really moving? Ensuring that there's transparent communication. And one example of something that made it easier for our providers in acute care, for example, is we provided the doctors with scripts. So we gave them scripts that was printed out with their pre-printed order of how to do an informed consent discussion around HIV. So they didn't have to make it up or think about it. It was written down in front of them, and they could just pick up the form and say, literally read it off the form if they so needed. But we also knew then that the right discussion was occurring because the right information was in there. We need to build trust with each other as health authorities, with our patients, and leave the door open for our clients. So if they turn us down, that's their right to do so. But leave the door open. Too much in healthcare, we have if you decide that you don't want to come to that appointment or you're not interested right now, we kind of shut the door behind you and say thank you. But leave the door open and revisit it with people. So if someone refuses an HIV test, when we see them again in 6 months routinely, to re-have that discussion, or to say to them, well, if you ever change your mind, you can come back and find me. Improving how we measure success. People were concerned, rightly so, around what are we measuring. At the moment, we've used a lot of biomedical markers during the pilot project. We really need to expand that out to include quality of life measures and the social determinants of health. Look at the proximity of service provision. One thing that worked extremely well is having our peer program embedded into the clinical system, literally, by having a room in the clinic, because the bridge between community and acute services, it can be a bridge to nowhere. If you say to someone, well, here's the address of Positive Living, go down and make an appointment, for many patients that will never happen. 2 blocks is too far. So the closer we are and the more integrated we are, the easier it is to get patients integrated into the system and not lost. Ensure that we're all talking about the same thing, that we're looking at, particularly around HIV testing and HIV risk, that we're talking about behaviors, not identities. Not assuming that because someone's gay, they're practicing sex in a certain way, and having that assumption made about you. Allowing the status quo to be challenged, which requires a lot of bravery because it requires not only leaders to lead with passion, but allowing your staff to lead with passion as well. And that can be an uncomfortable dynamic sometimes. We talked at one of the tables around how passionate people are really difficult to manage. Yeah, that's my whole team. All of them. But embracing that, because it's about be challenged, be questioned, allow ourselves to be questioned and pushed, and allow ourselves to be made feel a bit more uncomfortable than we do currently. The importance of system readiness. So if we're looking at introducing peers, for example, one of the things that we learned is that you need a lot of upfront clarification with staff. You need to kind of get those things fleshed out very, very clearly to avoid the bumps in the road. To make sure that there's clear expectations on roles and boundaries and systems so that everyone's singing from the same hymn sheet straight away. Staff aren't confused, the peers aren't confused, and patients aren't confused. Had we done a little bit more work around that, we could have saved ourselves about a month of turbulence.
Community as well.
Yeah, and the community as well, getting them ready. And also the whole concept of ensuring that we leave no one behind. That goes for our patients. For staff, I'm a great believer in there's always going to be 10% of your staff that don't want to change and don't want to do it. Don't focus on them. Focus on the 90% who do want to change. Allow people to self-select out of the system. So the old paradigm is to spend 80% of your time on 20% of your staff, and it's about flipping that on its head and spending your time with the people that are engaged. The other people will either come with you or they won't. But don't waste all of your time and energy on the people that aren't ready to change yet. Go with those that are the real champions. And ensure that our patients, often the most vulnerable, are not left behind. So we need to challenge the system. I know one of the questions that came up was around the uninsured. And that was a huge issue for us in Vancouver. It has taken since the beginning of STOP to this month. But we've done it, and the Ministry of Health have now created an MSP code for uninsured. So we can ensure that all HIV blood work, HIV testing is now available to everyone regardless of your status for 9 months, for a 9-month period. It's just come out and it will be ready for all of the province, all of the health authorities to use by the time that you're ready to gear up with STOP activities. So we have, and Gina's not here now, is she? Gina McGowan? Did she disappear? Gina McGowan, who's one of our ministry analysts, has been probably the key leader in the ministry. We're forever grateful to Gina for the hard work she's done, constantly pushing MSP to make this positive decision. So that's our summary. Thank you very much for a rich discussion. I hope everyone learned something, and please enjoy a break before the final session of the day.
Can I say one thing? CATIE and the Knowledge Exchange project, we want to talk about that a little bit because before I know how this project gets started, my part of it anyway, we have a narrative coming out.
Yes. All of the for Vancouver STOP, all of the projects that we've done, we have got our wonderful CATIE collaborators, and Christy Johnson is here, as is Laurie Edmonston is here as well, who's the executive director for CATIE, who've done a lot of case studies and narratives, and all of those are in their final stages and will be published on the CATIE website, and we will certainly ensure that the ministry will let everyone know provincially when that does happen, because they're going to provide some really use-rich data for you to be able to go to and read a little bit more about each of the programs and pilots that we've done.